This is the Transition Series, Topics for the EMT, Topic 13, Critical Thinking. Our objectives are to define critical thinking and how it relates to the EMT, understand the importance of determining life threats, and discuss how to develop a differential diagnosis based on assessment findings. Although difficult to define, critical thinking is an important skill for every EMS provider. The ability to think critically is needed by EMS providers at every level and will be a strong measure of clinical success. The concept is not easily defined, quantified, or taught. Your initial EMT class presented a patient assessment process that probably looked like a neat diagram. You might have thought it was the way assessments would go in the real world. Experience has taught you that those guides were just that, guides, and that many variables are considered in assessment. Assessment is not a static process. It is always dynamic. We constantly reevaluate our patients, comparing their current condition with our earlier observations. Many EMTs might assess the same patient and would demonstrate equally effective ways to ask history questions and do a physical assessment. One consistent rule is, address life threats first. Medical theorists describe critical thinking processes as having three parts: medical inquiry, the history, physical exam, and diagnostic testing; clinical decision-making, the cognitive process that evaluates information to diagnose or manage a patient's condition; and clinical reasoning, where medical inquiry and clinical decision-making combine to draw conclusions and guide future care. In fact, proper decisions are made only after evaluating the necessary and accurate information. The relationship between decision-making and reasoning is that the latter is a continuous process, a feedback loop rather than a straight line from assessment to care. New information is evaluated as it is obtained and applied to the body of knowledge about the patient's condition and filtered through practicality, risks, and benefits. An EMT using a technical approach follows a protocol, as one might follow a cookbook. Following the protocol, she listens to the patient's lungs, hears wheezing, and gives a breathing treatment. The approach to the patient is to find specific symptoms and provide a specific treatment. An EMT using a clinician's viewpoint takes more of a big picture view. She uses clinical thinking as she assesses the patient. When she hears wheezing, she wants to determine why it's present, to provide treatment addressing the underlying cause. She considers the many reasons for wheezes and gathers history and other clinical findings to determine which protocols are most appropriate to assure success. She approaches the patient to sort out the puzzle pieces, evaluate potential treatment outcomes, prioritize, implement, and evaluate them. Primary assessment is the foundation for all subsequent treatment. It cannot be completed without laying hands on the patient. The goal is to identify significant loss of function in the patient's airway, breathing, or circulation. Careful observation is critical. Something as simple as noticing cool, moist skin and a rapid pulse early in the process alerts the EMT to the possibility of shock long before vital signs are taken. During the primary assessment, the EMT should assess for breathing problems by exposing the patient, using a stethoscope, and in some cases palpating. Obvious life threats, like pneumothorax, open chest injury, and inadequate breathing, should be recognized and treated immediately. You can assess for shock by quickly noting skin condition, pulse rate, and quality. And we should always quickly determine whether the patient is a load-and-go priority. Immediate support for any lost function must be implemented, including oxygen administration, ventilation, control of bleeding, and care for shock. We support any lost function first, and then progress to differential diagnosis second. Here's a patient receiving the very first steps in a primary assessment. The EMT should use the chief presenting complaint as a direction of travel, not as a final destination. Consider the following case. EMS is called to a patient who complains of chest pain. He's a 55-year-old male with a history of angina and hypertension. He describes the pain as slightly to the left of the center of his chest, tearing in nature and radiating to his throat. He says it is different from any angina he has had in the past. He states he took one nitroglycerin tablet without relief. Functioning as a technician, an EMT simply assists the patient with a second nitro dose per the chest pain protocol. Additional lines of questioning may lead the clinician to a totally different presumptive diagnosis than simply inferring that all chest pain is from a cardiac event. Chest pain is one complaint for which a differential diagnostic approach is important. An EMT working from a clinician's perspective would consider other possible causes for chest pain. She might consider the patient's use of the word tearing as a possible indicator of a non-cardiac event, such as an aortic dissection. She will carefully consider supporting information before making a treatment decision, and think about options other than simply a cardiac event, such as pneumonia, pneumothorax, aortic dissection, pulmonary embolus, or trauma. Here are examples of a differential diagnosis which can be included in or excluded from a presumptive diagnosis by detailed history, absence findings, and physical findings that are relevant. Cardiac events such as ischemia and an infarct can be deduced from the absence of other conditions during the assessment process. Pneumonia can be identified by the presence of fever and chills, productive cough, and a gradual onset. Pneumothorax may be suspected with the sudden loss of lung sounds on one side of the chest and should be differentiated from pleuritic pain. Proximal aortal dissection will have specific pain characteristics, and so forth. You can review this chart in your book. Patient care is a balancing act. We balance needs versus risks, standing orders and online consults, needs at the scene versus hospital care to follow. Care plans fit into the continuum of clinical reasoning in that constant monitoring for therapeutic benefit or adverse reaction is necessary, and the patient's response to a particular modality may be diagnostic. For example, if a patient's chest pain decreases after the administration of nitro and with rest, we may presume that the patient's underlying condition was angina pectoris, whereas if the patient is administered nitroglycerin and receives no relief from the chest pain, the patient may be suffering from a myocardial infarction. In summary, caring for patients is more than performing specific skills based on specific findings, the technician's approach. To get to the underlying cause, the EMT will often have to look past the obvious to uncover the true etiology or origin of the emergency in a clinician's approach.